Good morning and happy Friday, everyone. I am your moderator today. My name is Patrice. I'm here to introduce Dr. Andrew Esch. He is a palliative care specialist focusing on improving the quality of life for patients and families living with serious illness. He earned his medical degree from the University of Buffalo, where he also earned a combined Bachelor of Science and Master of Business Administration degree. Before becoming the Senior Education Advisor at the Center to Advance Palliative Care, Dr. Esch was a CAPC consultant and faculty member. And prior to joining CAPC, Dr. Esch was Medical Director of Palliative Care at Lee Memorial Health System in Fort Myers, Florida. We are honored to have you here today, Andy, to talk about billing quick tips. And thank you for being here.
Well, thank you all for having me. Billing, it's difficult to, I think, distill billing down into anything meaningful in a short period of time. But as I was preparing for this, the approach I wanted to take was the following. I think since 2013, CMS has made a real effort that has benefited us. And this is awkward for me to talk positively about CMS. So if you're all rolling your eyes, I don't disagree. But since 2013, they've really opened up a lot of opportunity for us to get compensated for things that we just do naturally in a given day that historically had not been compensated. And so what I'm going to try to do in the 10, 15 minutes or so that I kind of walk through this part before we do questions is just kind of outline what are some of the big changes that have happened in the last 10 years in billing. What are the real high impact areas for palliative care, and where we probably are leaving money on the table and could be doing a better job, and just try to point those out to you. Our tools on billing on the CAPC website would be a good reference for you to go back if you want more on any of these given subjects. And the other thing I would point you to is an on-demand webinar that was recorded in the beginning of February, given by Chris Jones and Phil Rogers, that sits on the CAPC website. That is a good investment of 60 minutes of your time. They're actually entertaining. They make billing a lot less boring, and it covers a lot of what I'm going to try to cover in much less time here. You'll even see some of the slides I borrowed from that talk. So I think the highlights of what the high impact areas for billing right now are, in 2022 and 2023, they changed how we could bill on complexity. And they have changed recently how we bill on time. So I'll start with time. If you're going to be doing any time-based billing, time is now based on all of the time that's spent on the day of service, which really opens up. I have a slide in a bit that will talk about what's included in that time, but the upshot of this is it's really all the time on the day of service. So your chart review, you're collaborating with the referring clinicians, all those other things are going to be part of your time, which helps us to get to thresholds a lot easier than we used to be able to. And complexity is a recent change. They did it first in the outpatient world for 2022, and then in 2023, the inpatient billing changed on complexity too. So it's now based on medical decision making and not how many reviews of systems and other silly things we did to bloat our notes up to make them a billing tool. So this idea that you can bill on your medical decision making based on the complexity of the problems, the data, and the risk to the patient really have helped palliative care clinicians reach pretty easy to achieve levels of coding just by nature of the patients we get referred and the work that we do. Other highlights that have come on, and these are more on the outpatient side, so I'm not going to delve real deeply into those because my understanding is a lot of the folks on this call are inpatient, but there are new codes for billing for a complexity add-on, doing social determinants of health assessments, and then billing for what's called principal illness navigation or community health integration. I have a couple slides on those. These are outpatient codes. There still are prolonged service codes, but they pay pretty poorly. So with the time-based billing being all day, a day of service, you may not find that you're going to be using those as much as maybe you have in the past. And then I'm also going to talk just a quick bit about advanced care planning. because the ACP codes are our friends still. So just a little bit about time versus complexity. Time is now all the time on the day of service. So this is like, you know, consulting with your team, talking to the patient and family, going into the EHR, you know, when you got the angry family member that comes in from out of town, talking to that person, all of this rolls up under your time for the day of service. Now, the thresholds for time went up in 2023. So to get your highest level of new visit, you got to get to 75 minutes. But if you think about that, that's not all face-to-face time and all the stuff that they held us to before. There's no more of this 50% of time spent on counseling nonsense that we used to have to document. This is really all the time you spent in a day meeting the needs of that patient. And then the threshold is now 50 minutes for a subsequent visit on the inpatient side. Now you can add prolonged codes onto these. So, you know, it's 15-minute increments. So if you did meet the 75-minute threshold for a new patient, you could also add on a prolonged service code once you got to that 90-minute threshold. And then for subsequent visits, that threshold would be 65 minutes. But again, that's not going to pay you a whole lot. And honestly, given some of the other billing tools we have, you may not find you're going to be using those as much. So what counts towards time? Preparation to see the patients, reviewing the history, performing the exam, counseling, education, ordering meds, referring and communicating with other health professionals. Communicating through your electronic health record is not considered part of the time. This is actually picking up the phone or running into somebody in the hall. Documenting, interpreting the test results, and any care coordination that's not covered with maybe other billing codes that cover care coordination. So you can see it's like basically the work we do counts towards time, which makes it pretty easy to reach those thresholds. Now, medical decision-making, it's lectures in and of itself, not even one lecture, but it is defined by 3 elements. Basically, what is the complexity of the problem? How much data did you need to analyze to come to your conclusion? And what is the risk of complications of morbidity or mortality to the patient? To bill on medical decision-making, you take the highest 2 out of those 3. So if you score the highest level on 2 out of 3 of those, you can bill at the highest level of coding. And we have a lot of good content on this on the CAPC website, and I'm sure there's other resources too. But I would get familiar with the medical decision-making tables and these 3 elements. But the takeaway I want everyone to get today is that palliative care people undervalue what we do with our patients all the time. We take for granted that we do these opioid management, for instance. We use methadone a lot. You know, prescribing somebody methadone, doing a trial, monitoring them, that is complex, and it carries risk to the patient. And it takes data review, especially if you're doing EKGs and other things. So it is pretty easy to get to these very high levels of billing for medical decision-making because the patients we get are usually very complex. They're usually pretty advanced in their illness. They come to us with a lot of data, and the things that we do that we take for granted are actually pretty complex if you try to get some of our colleagues to do them, which I'm sure you've experienced in your practice. So my note on medical decision-making is don't undervalue yourself. Really look at the criteria from CMS, and you'll find that you're going to get to high levels of codes pretty easily. There's a lot of text on this screen. What I want to say about the complexity add-on is if you're doing outpatient work and you know, you're billing a normal E&M code, but you're doing sort of ongoing, continuing care for this patient for, say, unmanaged pain or a complex symptom, maybe uncontrolled nausea or something like that. So they have a serious condition, they maybe have lung cancer, but they're experiencing pain and other things, and you're following these folks longitudinally. You can bill, when you see them, something called a complex add-on code. It only pays around $16, but when you have a relationship with a patient, you're seeing them for an ongoing problem, every little bit helps, and this code is now available. This is probably the code CMS is most worried about, is blowing up the whole billing system, because family practice, internal medicine, outpatient practices. There are a lot of people that see complex patients in a longitudinal way. So this could really generate a lot of revenue just by scope of how much it's used, even though it doesn't pay that much. Social determinant of health assessment. This is when you administer a standardized evidence-based risk assessment tool, usually pretty quick. Again, it doesn't pay a lot, $18 if you're outside in a non-facility, $8 if you're in a facility, but it's a pretty quick tool, 5 to 15 minutes, and it really helps identify some of the social determinants that influence our patients. So I bring this up because this can be done on discharge from the hospital and is billable at that time as well. So principal illness navigation and community health integration are also outpatient codes. Just a quick note, think of principal illness navigation for people who have medical problems that you're treating and are going to be ongoing, and you're going to be helping them navigate through that. Community health integration is those folks that maybe don't have the serious illness, but they have a lot of unmet social needs, access to medications, access to good, healthy food, whatever it may be that is giving them, lack of access in the community. Those are sort of the things you unearth on the social determinant of health screen. So I like this slide. This helps me keep it straight. When you do a medical visit and you screen them for social needs, if they have a serious medical illness and some of the social determinant of health needs, use principal illness navigation. It's going to be where you are getting reimbursed for the work that your staff does. Will count towards the time. So it's people without MPI numbers, their time can be included in this. And you could also build principal care management as well. But the principal illness navigation is a very, very good way to get reimbursed for some of the time that your non-clinical staff is spending with your patients. And then the social determinant of health needs only, like they don't have serious illness, but they have social determinant of health needs, you can build community health integration. Again, incorporating non-NPI providers' time into billing for outpatient visits. The last note I want to make about some of the sort of sweeping billing changes that have happened over the last few years is don't sleep on the advanced care planning codes. They are still widely underutilized. And they really reflect a lot of the work that I think we all do in our interactions with patients. Helping patients understand their healthcare options, deciding what treatments align with their goals, sharing personal values and goals of care. All of this stuff rolls up under, planning. And so a lot of the work we do when we're in with families and caregivers is really in line with what ACP billing was meant for. And the RVUs are great. The work-related RVUs on these codes are excellent, like 1.5 for the first 30 minutes. And the next 30 after that is another 1.4 WRVUs. And what I love about this is the threshold to pay these is at 16 minutes. And so if you do an advanced care planning discussion with somebody and you get to that 16-minute threshold, you can build a 99497 code and tack on another 1.5 WRVUs, which just the component attributable to the WRVU is $73. So it's very good. So you do need to document what you talked about. You need to document that the patient and family voluntarily participated. Don't bill these in conjunction with other time codes. If you do a complexity visit, if you manage somebody for their pain in the morning or other symptoms, and then the family comes in the afternoon and you do a discussion about goals of care and things like that, bill your E&M code based on medical decision-making for the morning part of it, but then bill the ACP code separately based on time. Generally speaking, the feedback we're getting from organizations that we have reached out to is that if you're trying to build two time-based codes for the same patient, a lot of times those are getting kicked back and rejected. Like, why wouldn't you just accumulate all the time based on one time code? So bill on complexity for the complexity part of the visit, and then bill on time for the ACP part. Okay, I'm out of breath. I'm going to pause. I will just open it up to questions that anybody might have.
So the first question, we've got a couple questions from Marty. Marty, do you want to ask them or should I?
I'm happy to ask. So
Okay.
my first one is the day of service. So is that by date or is that by 24 hours? Because if I've got a really busy clinic and I'm reading about some of my patients the night before in order to make ends meet, am I able to still bill for some of that?
Yeah, I'll get clarification. My understanding is it is a 24-hour period. The the only caveat to that is if you go beyond the 75, let's say it's a new patient, you go beyond the 75 minutes and you're going to start billing the prolonged codes too, you have a longer window for that. You can start adding that on for days after. I think it's actually a full 7-day window for that. Um,
Hmm.
that may be specific to the outpatient side. I'll follow up and get that answer for you if I can find it. And I'll reach out to Chris Jones and some of the others I work with on billing to see if I can get you a more specific answer to that, Martin.
Thank you.
And
And then
before we move on, sorry, Marty, but if you could also answer or find the answer, how would that need to be reflected in the charting as well?
Yeah, we'll do.
Thank you.
my other question is you put up the RVUs for advanced care planning, so about 1.5. How does that compare to the prolonged codes? Because I have heard that that's quite a bit less, just like you suggested. Do you know offhand?
Yeah, I'm gonna look it up real quick.
Perfect. I appreciate it. Because that certainly has been the focus of our team and our education, that we should be focusing on really using the advanced care planning codes rather than prolonged codes.
Yeah. Yeah, I'll be looking that up. You can go on to other questions and I'll be looking that up and
Okay. Yeah, wonderful.
Other questions? I have a few in my back pocket, but I want to open it up to the group. Okay. This might be an unpopular opinion or question, but that's why we're here. You know, the social determinants of health and the complexity codes, you know, I think we have an obligation. I'm a huge proponent of billing for the services that we provide. And I think we have a compliance obligation to bill accordingly, right? But it could be argued that some of those are kind of against the philosophy of palliative care and kind of nickel and diming kind of ways of going about it. And so I'm wondering if you see any pitfalls or if you've seen any pushback from patients or inability to pay, or not so much pay, but follow up because it's just getting too expensive.
yeah, so good question. One of the things that CMS I think has been really good about doing is there's usually not co-pays involved with a lot of these codes. So, you know, the patient might see it on their explanation of benefits, but it's not going to be impacting them out of pocket. So we haven't gotten a lot of blowback on that. Certainly the intention of this is not to have palliative care people do more work that will generate more revenue at the expense of patients. I think what these CMS codes have done, the outcome of them has been, is that it has allowed us to just actually recuperate some income, even though it's very small amounts, for work we're already doing. And so the tricky part to me, Patrice, is your medical note now serves many purposes. It's a communication tool between clinicians. Great. It's a medical legal document, maybe not so great. So you're documenting a lot of things just to make sure you're kind of covering yourself. And the other thing is now with open notes, since when did that go into effect? 2022, I think. Patients have access to their chart and most of the information in it. So you need to be writing your notes in a way that makes sense to the patient. So if you're just billing, if you're just billing, or if you're just doing things for the sake of generating billing and sort of like writing haphazardly in your note about that, it's going to be pretty obvious to the patient and family. But if it's part of what you did in that room and it's just documented as such, you know, I had this advanced care planning conversation with the patient and family, and that reflects what they remember that visit to be, we're not finding that people are pushing back on that. So I just think if we're doing, I think your billing and coding should tell the same story your note does. It should be a way for somebody to look at those numbers, those E&M codes and what you build, and be able to sort of deduce what happened in that room. And I think that applies to patients too, especially now that they have access to the notes. I hope that answered it.
It did. Thank you very much. That's very helpful. Other questions?
Andy, when you're doing your billing statement at the end, how much detail are you going into there to explicitly document what you're doing and explaining how you're meeting these criteria? Or are you just simply putting the codes and letting the note above tell that story?
I'm much more specific when I bill on time. Because medical decision making can be, to me, that's, I reviewed the history, I talked to the oncologist, the patient has these diagnoses, like all the stuff that would be in your note is really telling the biller and coder the data points, the complexity of the patient and the risk that they're under. So I usually, just in the nature of writing my normal note on medical decision making, I don't worry about that, because I think that story is told in the patient history and in the exam and everything else. I will just make a note about physical exam. With medical decision making, physical exam is really not counted other than just, as part of like something that you did to the patient, but it doesn't really impact your billing revenue that much. But that's not to say you shouldn't be still doing a physical exam. There's obviously other reasons to do that. And medical legally, you're going to want that documented too. So I just write my normal note when I do medical decision making. I just don't worry about that. And generally speaking, everything I put in is going to meet the medical decision making criteria. Now with time-based, you're going to want anybody that's auditing that note or a biller and coder in your organization to be able to do I call it the head nod criteria. Like, I want them to be able to read my note and sort of nod and say, oh, okay, I can see why that would have taken 45 minutes, or I can see why that would take 60 minutes. So you need to be pretty specific about that. Met with, these family members. We discussed these issues. These were the concerns brought up. So I'm pretty, my time-based notes are longer and written differently than my medical decision-making notes. And part of that's for billing. Part of that so everybody knew what we talked about in the room. And part of that is because I know my families are going to be opening up their My Chart and they're going to be looking and they're going to see what's in there. And I want that to reflect what was discussed in the room. So I think time-based notes, you need to be a little bit more prescriptive.
Even though this isn't exactly why you're here, can we get your perspective on how you've written notes differently now that patients and families are having access to them?
Yeah. For me, I'm in my mid-50s. I trained at a time where we did not use inclusive language. We used, a patient with sickle cell disease was a sickler, or, I would write my notes very quickly and I would use a lot of stigmatizing language in my notes. And I think a lot of people that trained in my generation did. So for me, it's been a lot more sensitive to using inclusive language, trying to improve on my cultural humility skills. So I'm sort of documenting some of the nuance that comes out when you have patients from different backgrounds. For me, it's been a pretty good effort to put in, because I don't want my note to have the unintended consequence of eroding the trust or the relationship I have with a patient, because I just, in the excuse of being crushed for time, wrote something insensitive in my notes. So it has slowed me down, but I think in a good way, because it's made me more thoughtful, and just practicing writing notes that way has also helped with how I communicate with my patients too, because I use more person first language and things like that. So I'd be curious to see how everybody, if anybody else has an answer to that question, because I think it has changed the way we've written notes, but that's how it's affected me the most.
We had a colleague here who prints out his note at the end and hands it to the patient and says, here's my understanding of what we all talked about. What do you think? And lets them look at it almost with like a red pen and change things, and they'll discuss if they've had a mutual understanding, which is curious, and I've never seen that before.
Yeah.
Though I think you avoid a lot of that by just simply, our natural tendency is to summarize at the end. Here are the things we've discussed. Here's the journey we've taken. And I think if you're right on that summary, it would be unlikely a family would be surprised to find what's in your note.
Right.
I would say that the biggest impact, if there was one, for myself in the open note, is being careful about writing things in my thought process that maybe the patient wasn't ready to hear, such as prognosis or recommendation for code status. And while I sometimes in the past would want to make note of something like that for all the reasons, for the communication tool pieces, the legal pieces, all of the other pieces that you mentioned of what the purpose your note serves, I now hold back on that. And I don't really know if that's problematic or not. I think in some cases it can take away some of the things that you're doing. So that's not a question, but just a general comment.
Yeah. I'm generally, I not generally, I mean, I am 100% feel like that information should be available to patients, but it does create burden on the note writer. It just does. I mean, the medical note has too many purposes right now. It's impossible to write a great note that your colleagues can understand and really know what you're thinking without running the risk of, if I have somebody who's maybe having trouble with their opioid prescription and I'm pretty worried about, aberrant use or diversion, I don't want to be writing that in my note. Like that might be now I pick up the phone call and I say, listen, like, I don't know yet, but here's my suspicion. Like I'm going to be tracking this patient more closely. But, if I write all that in the note, like I might have historically, that patient's going to look at it. And if I'm wrong, they're going to be upset, and rightfully so. So, I mean, yeah, it's
tricky.
Yeah, it's tricky. I think ultimately it's good. I think patients should have access to their information. They shouldn't have to fill out forms and wait weeks to get things sent. Like I generally love it. It has impacted me. I wish I would have, if I trained this way all along, I think it would have been feeling less abrupt to me than it has felt.
Sure. Okay. I'm not seeing any other questions in the chat, so I think we'll conclude today. Thank you so much, Andy. This has been really helpful.
Yeah, I will get the answer to the 24-hour period and how you go about documenting that. And I don't know why I'm having trouble finding. I think it's 0.7 WRVUs, but I will find that out for sure on the prolonged code and let you know.
Okay, yeah, you can just send it to Marty or myself or both, and we can send it out to the group. So thanks so much.
Yeah. Thank you all for having me.
All right. Have a good day, everyone.
Bye-bye.